Majan here at the Duke Spine Institute, CEO and founder, and it is August 24th, 2021. Well, before you open it, let's see what we got. He might be all right with that, Luis. I think we're okay. Yeah. It's just up by the wrist. Not a big deal. Just tell him to hold on.
Stand by.
Thank you, though. We don't need it. All right. So this is going to be our third surgery for today, and this patient is having something called the Duke laser disc repair, which is endoscopic surgery of the spine. She did not want an open surgery. She wanted something done less invasive, and thank God we have that technology now to do pretty much everything that needs to be done for degenerative conditions of the spine. We can do it with the endoscope. All right, are you comfy? All right, Dr. Duke here. We're going to get started, okay? That's just my hand palpating and feeling around to figure out where we are. I'm using your hips and checking things out. All right, so on the left side where I'm standing, we're doing 2, 3, 3, 4. Everybody agree? We're going to give you some numbing medicine. You'll feel a little stick and burn, all right? Don't get angry. If you feel pain, just say ouch. Okay? All right. You'll feel a little stick and burn. You're going to feel a little ouch. And I'm just giving you some numbing medicine. It's totally normal to feel a little burning now. Okay? I'm sorry. I wish it was a little more comfortable. Yeah, I know. I know. Why does numbing medicine hurt going in anyway? Is it the acidity?
It's a high pKa.
So it's the acidity. And does bicarbonate? No, you need the needle. It does? So why don't we use some bicarbonate?
Standby bicarbonate for 10 cc.
Let's do that. Let's see if it makes it better. Okay? Luis?
Yes, sir.
A cc of bicarbonate per 10 cc's.
Thank you.
All right, so we're going to start at, I guess, L2-3 shot. Let's go lateral. Maybe a little higher than I want to be, but there's only one way to find out. That's to use the x-ray machine. We use our x-ray machine called a fluoroscope to navigate. And navigation basically means, come south, it means using landmarks, in this case spine marks, to figure out where we need to go. Drop the table a smidge. That's good. Shot. All right. So we need to, let's see what we can do here. What can we do to make that picture better? I think we need to bring the table up a little bit. We went down a little too much. Good? All right, shot. All right, it looks like there's some osteoporosis. So their bone mineralization is not great. I'm going to need you to get me a better view. So let's start with 5, 4, 3, 2, 2, 3. You see 2, 3 up there? Shot. It's got that. Just lay still. It's real important you're not moving around, okay? All right, I need you to zoom in. You need to bring this side closer. Shot. That looks like 2, 3. And it's pretty close, but we need to zoom out a little bit. You got me a little too much. Just a little. A little more. Good. All right, try that. All right. I think that's 2, 3. We'll verify that in a moment. Are you comfy? All right. If you have pain, tell me, local, and I will give you more numbing medicine, okay? And if you don't have pain, just lay quietly and get some rest. If you have pain, say ouch and tell me if it's in your back or your leg, okay? All right. Here, needle down. How's blood pressure?
It's epinephrine. 18 and epinephrine.
Okay. All right. With epinephrine. Shot. So I think we need to see more in the back here. You're doing great. Everything's okay. Uh-huh. Shot. All right, so higher than I want to be. Higher. Can you come south just a little bit? Shot. All right, I think that's 5, 4, 3, 2. 2, 3, right? 2, 3 is where we want to be, the highest. Let's come back south. All right, that's good. So 5, 4, 3, 2. Show me 2, 3. Nicely. All right, that looks like 2, 3. And now we got to do something with your orbit. Everything okay, Doc?
Yeah.
Shot. Shot. Show me more in the back. That's good. That's good. It's too much. Just a little bit. Come on. Come on, Jordan. Little changes. This is a detail, surgery detail. 5, 4, 3, 2. I think I can be a little bit lower.
Can you show me those?
Shot. All right. Everything okay?
Yes.
Let's get some more numbing medicine.
How about the card? Like a packages?
This medicine will ease some of the discomfort of the initial part of the surgery, which is accessing the disc that we're trying to treat, which is what we're doing right now. So she has 4 herniated discs. We're doing 2 of them from the left side and 2 from the right. Let's go down just a little bit more. Let me see where we are. Shot. Shot. 5, 4, 3, 2. Shot. That's the facet. Shot. Yeah. I'm pretty sure that's 2, 3. There's 5, 4, 3, 2. We'll have to verify that in a moment. Shot. All right, let's get an AP. 5, 4, 3, 2. 5, 4, 3, 2. So we're right up against the facet joints, I believe. I need to be a little more lateral. You're doing great. Yeah. So Let's just say 5, 4, 3. All right, back to a lateral. It's really hard to count on the AP view, the front view. But it's very easy to count on the side view. So there's sacrum. There's 5, 4, 3, 2. Yeah, I think we're good. Just need to be a little bit more lateral. Shot. Shot. You're okay, I promise. Shot. Shot. Yeah, this is all that arthritis in your spine. We have to get past it to get to your disc. Shot. That arthritis is in your facet joints. Shot. Shot. You're okay.
What? Yeah, just what you did. Oh, or 11.
Shot. 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 Now she does have some scoliosis, which does make it harder to get to where we need to go. Shot. Getting closer. Shot. Are you comfy? You'd be more comfortable at home on a lounge chair, I'm sure. But everything's going really good. Let's get an AP view. So we're aiming for that disc right there. And there's a 5, 4, 3, 2. It's a 2-3 disc. And we always want to check your positioning with AP and lateral. That looks good. Back to a lateral. You're doing great. She's being a great patient. She's laying still. She's communicating with us when she feels any discomfort. That's exactly what we want. It's beautiful. Shot. Oh, there's a big tear there. That was easy. Yeah. All right, you all right? Okay. Let's get some more local. You can actually go through the incision. It reduces the amount of pain and discomfort the patient experiences once you've made it. It was after I made it I realized she was still a bit uncomfortable. And I'm going to, so the left is 2, 3, 3, 4. The right is 4, 5, 5, 1. I'm going to give you your injection on the other side just right now so it starts working for us. Okay. All right. Needle down. Yeah, I think we're good. I think that's good. That's 7 millimeters. So the incision is 7 millimeters. We're going to do this endoscopic surgery through a 7 millimeter incision. It's one of the nice things about this procedure is it's all done with such a small incision. All right, I need to see the next disc. So that's going to be the, you can see the pedicles of 3, how they're not lined up?
Yes, sir.
Yeah, let's see what we can do to improve that. Take your time. Jordan has become quite an expert at doing the fluoro for this. That's much better, Jordan. I like it. I think orbit looks pretty good too. What do you think? Yeah? You agree? All right. Huh?
Can always be better somehow.
Yeah, I think if we move the whole thing south a little bit, it would be better, but I don't want to mess up your mojo here. So now I think we need to fix the orbit a little bit. We're about a degree off on orbit. Shot. Shot. You're okay. You're doing really good. Shot. Yep. This is the hardest part of the surgery, okay? For you and me both. So we're going to get through this. Just be patient. Shot. 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 All right. Shot. And one of the unique challenges patients with osteoporosis have is that, you know, we don't need great quality bone to do the surgery, but we need to see the bone to know where to go. Shot. So when you're dealing with osteoporosis in this type of surgery, the concern is not that the screws will get loose, because we're not putting any screws. The concern is, shot, is that you can't see the bones and the disc properly to be able to navigate down to the spine and do what you need to do. And with her, it's kind of on the border, shot, so to speak. Let's get an AP, because it's kind of fuzzy. If you notice, if you watch a lot of these, the outline of the bone is not great. You can't see the spine that well, and that a lot of times it's because the bone is not as mineralized as it normally is. And what we're talking about lateral is we're talking about the density of the bone. Do you know if you have osteopenia? Have you been checked? You have? Hmm? Oh, so you do have, she does have osteoporosis. All right. All right, we're going to do fine, Sean. So we're right there. We're very close to where we need to be. And the thing about osteopenia and osteoporosis is you could actually push yourself into the bone itself, which we don't want to do. So I need to be in a little bit better position. Let me think. We're right there. I need to be a little bit higher. Shot. I want to come in a little bit higher than I was. Shot. Shot. That's better. Definitely better. Where do you feel that? Huh? In your back or your leg? Yeah. Tell me a little bit about your back pain. How long have you had back pain? How long? How many years? How many years have you had back pain? 8 years. 8 years. 8 years of back pain she suffered with. And we're going to fix it today. All right, we need to bring the base south, I think. And let's get lined up on 4-5 and 5-1. So 4-5 we're wagged off. I think you need to bring the base south a little more. Take a look at the iliac crest while Jordan's doing that. It runs right through the L4-5 disc space. All right, that's better, but let's get that 4-5 disc space lined up even better than that. I think you need to wag it. I honestly can't tell. Maybe that's worse. Let's try the other way. Shot. And you're pulsing?
Yes, sir.
Shot. Shot. What do you think, Louise? Worse? Worse? Let's go the other way. When surgeons use navigation for spine procedures, we use X-ray. That's better. We use X-ray radiation. And X-rays have a cumulative effect on people where they actually they have a temporary effect of being able to see the bones, but then they have a cumulative effect in terms of their effect on DNA. And it's the kind of effect we don't want normally. So you want to be careful about how much you get in your lifetime exposure to the X-rays. So we try to minimize our patients' X-ray exposure by doing techniques, certain techniques. Number one, you have to have a really good machine, which is, we have the best. Because the best machines give you the best picture. The best picture means you get better information more efficiently without having to shoot so many X-rays. Okay, it's kind of like when you take a picture of your friends with your iPhone or your phone. If you don't have a good phone, you don't like your picture because it's blurry, well then the first thing you're going to do is shoot another picture, right? And you're going to keep taking pictures until you actually get one that you're happy with. So it's the same thing with X-rays. If you don't get a good quality picture, then you're going to end up keep taking pictures until you get one that you like. And so it's important to have a good quality X-ray machine. You know what? Let's do 5-1 first. Come south a little more. 5-1's always the hardest to do, and I want to do that before I do 4-5. Because I don't want the needle for 4-5 to interfere with the needle for 5-1. I think that's pretty darn good. Yeah, I think we're a little bit off on our orbit, maybe 1 degree. Let's deorbit it or orbit it. Shot. I can't tell. That looks. Do you think that's worse or better? I think it's worse. What do you guys think? Maybe a little more. Let's see what happens. Yeah, that's good. So I think it's really important to understand you should not proceed with procedures where you use navigation like we're doing right now unless you have a good clear picture of what's going on. So as a surgeon, if you're using navigation for the spine, you want to be sure to have reliable information that you're navigating with. I think that might be, let's get an AP. It's probably going to be the iliac crest. Shot. It's got to be the other, closer to you. Just pull it closer to you. I think it's the iliac crest. It's got to be. Shot. Yeah, there it is. All right, let's go back to a lateral view. So what I'm getting at is you need your fluoro in position before you can navigate. Shot. Before you can navigate your needle. You really need to have the fluoro done. I think she moved a little bit. Lay still, sweetheart. You're doing really good. Huh? Oh. Okay. Shot. Is it better? Yeah. That was helpful. Thank you. Shot. Shot. Let's get an AP. See where we are. We're coming up on those facets. Any questions from our audience so far?
No questions just yet.
I think we're too medial. Let's go back. And shot. So this is the longest and hardest part of the surgery, but it's also the most important part. If you get this right, then you don't have any issues. Shot. Shot. That is a big arthritic facet joint. Shot. Well, we lined up pretty good. Shot. 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 All right, let's see if we can't. Are you comfy? Let's see if we can't get. Where do you feel that? AP. What'd she say? Down your leg? How far down? Let's get a quick shot. That's just not possible. It's perfect position. But is it better? Now you have pain down your right leg and left leg anyway, right? Let's go lateral. Is it the same kind of pain you normally get? And you felt a sharp pain? All right, I'm going to need you zoomed in here a lot more so I can really see what's going on. So that was very helpful, but we are so low. We are so low in the foramen. I think our orbit is off by the smallest amount, maybe even half a degree. If you could just make that a little better. I just want as clear a view as possible. Did that get better? Maybe? Lateral, no. Medial, yes. Any pain? Where? Huh? Your buttock, but not down your leg. Where's anesthesia? Oh, you okay? Just doing a few push-ups? Uh-oh. So she's not having any leg pain. We're right at the back of the disc. Yes? Oh, baby. Again. So funny. Can't even see it. That's incredible. But it's in there. That's amazing. All right. We did it. They say it's better to be lucky than good, right? I've had my fair share of luck. Let's just do a quick little one. Because I think that's it right there at the middle of the disc that we're seeing, but it kind of cuts out because it goes along the end plate. You know what I mean? Are you comfy? Yeah. How bad is that on a scale of 1 to 10? 11? All right. I apologize. Well, at least you got one discogram out of the way. Is that where you typically get back pain? Well, I couldn't hear what she said. Is that where you typically get pain? Just say yes or no. All right, yes. 11 out of 10 at L5S1. We're not ready yet. I really want to get this last one in. You're doing amazing, by the way. You really are. And I got one more to go. We got 3 discs tapped. I like that. Tapped. Huh. Huh? Yeah?
Yeah.
Hey, you helped me come up with a new word today. How's that for audience participation? Tapped. It's kind of like tapping a keg, but we're tapping the disc. Huh?
I like it.
All right. As long as you like it. You got to make this fun. I don't know how we got into 5-1, to be honest with you. I get lucky. Sometimes I feel like I get real lucky. All right. We need to get that 4-5 locked and loaded. We're a little bit off on orbit. Little off on Wagaloni. So basically we've accessed 3 discs out of the 4. Just get that pedicle lined up. What do you think? Think it looks good? I mean, it looks a little off to me. What do you think, Jordan? Keep working on it. I'm going to head in that direction. Shot. Shot. That looks pretty good. I think the dye has affected it, you know? I think the dye has come up. Shot. Too high. Shot. 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 That's better. Shot. Oh. You feel anything? Where? Huh? Shot. In your back or down your leg? All right, just relax. Feel like I'm hitting that disc. Shot. Close. AP, let's see where we are. Okay, so this procedure requires gaining access to the annular tears on the side that causes the leg symptoms, if they have any. Yeah, too far lateral. All right, so we know we're too far off. So that's what we're trying to do. We're trying to get to the spine, into the areas where the herniations are. And to do that, shot, we have to use what's called the spinal needle. And that's what we're doing. And this is the last one we need to do. Shot. 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 I'm sacrificing my hands for you. Okay? Shot. They're getting radiated. But it's all right, don't worry. Does that hurt? Where? How far down? I can't hear. Your calf? That we don't want. Shot. Shot. Is it better? Shot. Shot. Let's get an AP. So I had to make an adjustment because she said she felt something go down her leg. So that means we're a little too close to the nerve, and that's why the patients are awake for the surgery. If you don't keep your patient awake and you do something nasty to the nerve, everyone's going to be angry with you afterwards, okay? So the key is, the reason why patients stay awake for this part is to help me navigate right past the nerve roots, because we're literally 1 millimeter wrong direction, and it's really bad news. Okay, so we don't want that. I can feel the herniation. Anything? Huh? What'd she say? But not down your leg. I feel the herniations. I'm bouncing on it. It's like a beach ball shot. Okay. Better? All right. So you cannot be impatient and be a good neurosurgeon, or you'll have really a lot of complications. So folks, this is a patient with 4 herniated discs in her back. And her back pain, when I asked her, point to your back pain, she said it's this whole area here. Well, this whole area is more than one disc, okay? So I'm going to show you where these discs are. The L5S1 disc is right around here. She has a tear in the disc. The L45 disc is right around here. And then L34, and then L23, okay? So L5, S1, L4, 5, L3, 4, L2, 3. She pointed to this whole area in her back. And I knew from the MRI we had tears in multiple discs. So we've already tested what, L5S1?
Yes, sir.
And it was an 11/10. Okay? Are you comfy? All right, we're going to put you to sleep in just a couple of minutes, but I need your help. How bad is that on a scale of 1 to 10? Huh? 11? You like the number 11? Okay, you don't like the number 11. Well, that's 2 11s out of 10. So we found 2 of your bad discs. I just want to make sure we're doing what you need done to get rid of your back pain. How'd you find out about me? How'd you find out about Duke's spine? Huh? Oh, your brother-in-law told you? I know he was, but he told her about us? Hmm. How bad is that on a scale of 1 to 10? Oh.
Now, 2, 3, 11/10, 4, 5, 11/10 as well.
So this was an 11/10 as well. All right, now, if we were in Vegas, what would you bet? That the next one's going to be an 11/10. Do you want to bet? You want to have a little side bet with me? Right? Huh? You'll bet it all. That it's going to be 11/10? You're the one who comes up with a number. What better game to win than that? How bad is that on a scale of 1 to 10? I feel like I just won the slot machine or something. 11, 11, 11, 11. All right. You get to go to sleep, and when you wake up, all that pain you had, and that's where you typically get pain, right? All that pain is going to be gone. Isn't that going to be nice for the rest of your life? We're going to repair your disc with the Duke laser disc repair. All right. Can you count from 1 to 100 out loud? Yeah, count out loud, 1 to 100. Yep. You're doing great. Did you know you have blue blood, by the way? I'm just kidding. Keep going. Shot. Keep going. You're doing really good. Everything's going very good. All right. So basically, you see the discograms we did, L2, 3, 3, 4, 4, 5. All the discs have tears in the back. That's where her pain's coming from, the annular tear. And that's what the Duke laser disc repair does. We debride and clean out the annular tear. It gets rid of the back pain. It's the only surgery in the world that does it. And we were the first to publish this. So anybody that wants to look it up, type in Duke laser disc repair in PubMed, National Library of Medicine. You'll find it was published in Surgical Neurology International back in 2012. That was almost 10 years ago we made our first publication of this procedure. So now we're entering this L3-4 disc. Seems a little brutal with the banging, but it's necessary, I promise you. It's the safest way to get this thing in. We do this all the time. Don't try this at home with a family member. That's perfect. Now that we've got the dilator down, which is like a little metal pencil, now we put our tube. Let me just show you the tube so you can see what I'm doing. It looks like a shake straw, but it's actually, it's made out of stainless steel. A shake straw costs 1 cent. This thing costs $1,200, maybe $1,500 nowadays with inflation. $1,500. So if it was a shake straw shot, then we wouldn't have to spend so much money on it. But these are made in Germany. They're all FDA approved. Everything we do is FDA approved, 100%. Just so you know, if you try to do things like this in the United States that's not FDA approved, you go to jail. We don't do things that are illegal. We only do legal stuff. So all of this equipment, FDA approved. The surgery is peer reviewed and published in the National Library of Medicine. And I've done over 1,300 of these surgeries. Thank you, Luis. Perfect. You got it. Straight out. Don't wait. Gentle. Let go. Here. Perfect. We're inside the L3-4 disc. That's the first one we're going to do. So all of our surgeries are 100% FDA approved, peer reviewed and published, and they are not experimental. They are proven. The way you know something in medicine is proven is you do a study where you look at the outcomes of a treatment. And when you study the outcomes, and the outcomes are what you want them to be, you then write it up and you submit it to a scientific journal. And then your peers, which would be neurosurgeons and basically neurosurgeons, review your work and make sure that they may not agree with what you do, but they want to make sure it's scientifically sound and free of bias. And that's what the peer review process does. So we have peer reviewed and published this surgery multiple times. And here we are at little old Duke Spine Institute doing it again. Why do we do this surgery? This surgery is used to cure back pain and leg symptoms, or if it's in the neck pain and arm symptoms. In this patient, and actually all the patients today, it's for back pain. Why is the water hazy? Because there's the blue dye coming out. We had a lot of dye in that disc. I'm not able to grab any more of that material, so I'm going to use the laser fiber. Our laser's at 30 watts. And Jordan is basically, what do they call it when you work 2 jobs? Double timing it?
One-man band.
Huh? A one-man band? I don't hear any music. Sorry, I'm not going to give him the credit of being a band. But he's doing a one-man laser fluoro. And he's doing a fine job at it. So the laser is the blue fiber you're seeing at 12 o'clock. There's a lot of scar tissue here. That's why this stuff looks so chunky, so stuck together. It's not just vaporizing really easy. It's hard to get rid of because it's so scarred up. And it's unusual for it to be this scarred this deep. Okay, we're deep in the disc. We're at the base of the herniation. We're at the innermost part of the annulus. So there's no blood supply here. So you can't have scar tissue without a blood supply. You cannot get scar tissue without blood supply.
We have a question from YouTube.
Question?
Yes.
We've never entertained a question.
Oh, okay. Never mind
I'm
then.
joking.
All right.
Go ahead, fire away.
Well, our viewer just had back surgery on L3, 4, and 5, and now has a numb left leg and inner thigh. It's been 2 weeks. He wants to know what to do.
Yeah, so if you've just had surgery and you have just a numb leg and thigh, that's not uncommon, especially if you had a pinched nerve. I don't know your story, but if, let's say you had a pinched nerve, at a couple of pinched nerves actually, it sounds like, and you got the surgery done and they did a good decompression, and they did it really good. They did a perfect surgery. You could have a numb leg and thigh for about 6 months. That's common. Depends on how much nerve damage there was before they did the surgery. So I would expect there was nerve damage before they did the surgery and that you didn't not have numbness and now you have numbness. Let's say you didn't have any numbness or weakness or anything before surgery and now you do. Well, that's a problem. You need to go see your surgeon right away. But if you had weakness, numbness, tingling, pinched nerves, especially if you had an EMG nerve conduction study that showed radiculopathy, basically nerve damage, then they may have done a great job and you just have numbness and it takes 6 months to go away. And the reason numbness takes so long to go away is that numbness and weakness require the nerve to regrow. And the nerve grows at 1.4 millimeters per day. 1.4 millimeters. So you all know what a millimeter is. It's small. It's really got to grow from your back all the way down your leg, about 1.5 millimeters a day. So that takes a long time to grow. There's no way you can speed that up. So I don't know the circumstances of your surgery, but if you didn't have any leg problems before surgery and now you have numbness, I would be worried and I would talk to the surgeon. On the other hand, if you had nerve problems before surgery and you just have some numbness now, it sounds normal to me. I wouldn't be very concerned about it if it was my patient. I hope that helps. Now, if the numbness starts getting worse, if the numbness in your leg gets worse in the next 12 to 24 hours, you may have a blood clot in your back, and you need to go and get that blood clot taken out. So I would say the numbness needs to be stable or improving for you not to worry about it. All right, so this is the tear right here that we're here to fix. This is the whole reason she has back pain, the annular tear. And we're lasering, cleaning it up. This blue stuff is the herniation stuck in the tear. So the blue stuff is the nucleus pulposus, and normally the nucleus pulposus lives in the middle of the disc, but when you get a tear in the wall of the disc, on the outside wall, called the annulus fibrosus, or aka annular tear, if you get an annular tear, that lets the jelly or nucleus squeeze through the tear. Otherwise, the jelly is trapped inside the middle of the disc, and the only way it can get out is through a tear. So when a tear does happen from some kind of thing that you do, like sports or a car accident or something, where you tear the disc, some type of trauma, okay, then you get that tear going, and then the jelly can come out. And once the jelly starts coming out, we call that a herniation. And a lot of people get confused about herniated disc versus a bulging disc. A bulging disc and a herniated disc are the same thing. It's just that a bulging disc is a small herniation, contained. We call it contained. It means it's contained within the annular tear. So it's still a herniation, but it's just not extruded. And by the way, the vast majority of painful discs are contained or bulging rather than extruded. Extruded discs are rare. So most people's pain comes from a bulging disc. So when you go to the doctor and they tell you have a bulging disc, don't let them blow it off, because that's why you have your pain. You know, it's kind of like you're walking on the trail and you see a rattlesnake and somebody goes, "Oh, it's just a baby rattlesnake. It's okay. You can pick it up and play with it." No, you can't. They're worse than the big ones. They have more powerful venom. You don't want to play with a baby rattlesnake, and you don't want to leave a painful bulging disc alone. You want to fix it, because doesn't matter how big it is, they pack a powerful pain. And that's why people with bulging discs have so much pain. And their doctors, unfortunately, just tell them, "Oh yeah, it's just a bulging disc. That's not causing your pain." Yes, it is. Well, they don't know how to fix it either. This is the way you fix it: endoscopic Duke laser disc repair. We developed this treatment just for bulging discs that are painful. And you don't have to have a fusion. You don't have to have an artificial disc. You don't have to have narcotic painkillers the rest of your life, which don't fix this. They just help ease some of the symptoms. But you get addicted, and painting and everything they've done to curb the opioid pandemic has done nothing, at least in my opinion so far. Now we have apparently 18 deaths a day in Florida from opioids, pain pills. Why are people still being put on opioids? What is wrong with doctors? Send them to surgeons like me that can fix them. Don't commit them to opioids. I tell you, the world is so screwed up sometimes. 70% of heroin addicts on the street were made heroin addicts by doctors prescribing opioids, especially back in the 80s and 90s. OxyContin, oxycodone. So we as doctors are to blame. And now, of course, doctors, they don't want to refer their patients to a surgeon like me because they don't want to support us. But they're missing out on the point. They have a patient to think about and care about. Stand by. Problem is, some doctors just have their heads up their ass. They're not thinking about why they went into medicine. It's not for them, it's for the patients to get them better. So even today, 2021, there's a piece of herniation. We have more people dying every single day in Florida alone than ever before from prescription narcotics. Prescription given by doctors. Now, it doesn't mean that those people are dying from their own prescription. They could be, I guess, getting those narcotics from other people that were prescribed it. You know, people selling it on the street. I think an oxycodone goes for about $30 on the street. So people are going to the doctor saying they have pain, getting their oxycodone pills, and then selling them. And that's really bad. Once again, we've got to stop treating chronic pain with oxycodone or drugs. We have to fix it. And this surgery you're watching is the way to fix it. It's the only way to fix it. You can do a fusion too, but there's no reason to go through fusions, which are painful and dangerous, and you need oxycodone afterwards. There's no reason to go through fusions when we can fix the pain easily with this Duke laser disc repair that we developed here at Duke Spine. We've been doing this surgery now 15 years. Very safe. We've had 0 complications. 1% of the patients will re-herniate. They will do something to re-injure their disc again that I just fixed, and they'll need another surgery. That's 1%, 1 in 100. So it's not often, but it does happen. That's for sure. That's about the only downside to the procedure. But then again, Other types of spine surgery have a higher reoperation rate. With fusion, it's as high as 20%, maybe even 50% in some series, adjacent segment disease and reoperation. So taking the patient back to surgery again, doing another fusion at the level above or below. That's like literally 25 to 50%, depends on whose study you read. For me, when I do fusions, my adjacent level fusion rate is less than, it's about 2%. Hey, what's going on with irrigation? How come you keep forgetting about it? All right. Right, so you have it pressurized? Okay, good. Thanks. It just seems like we're getting some bubbles. When I start seeing bubbles, I know we don't have enough pressure. Just about done here, Luis. And then we'll go to the next one. So people, wake up and get your spine fixed, get your back pain fixed. Don't keep taking narcotics. Narcotics don't cure anything. Grabber. That's the last piece I need to get out right there. Any questions for me?
No.
No. But people know everything already? Huh? They're smarter than all of us? This is your chance to ask a neurosurgeon a question and not have to pay him. We do all this for free. We should be sponsored by Nike. Just do it. You like that? Luis liked that. I like that. All right. The nerve is right there, that white thing. And if we're at, what level are we at? 3, 4? No, what are we at? 2, 3, 3, 4? 3, 4. So that would be the L3 nerve root on the left. Why is my suction not working here? My suction's not working up here. I need it working. Thank you. That's perfect. Alrighty then. All right, so we're coming out with this one and we'll go in with the next one. Take. We need some grease on there, right? Let's get that fluoroscope in. So the first patient did great. He has no more back pain at 5 level. He just had soreness where I did his surgery. But his facet pain's gone, his disc pain is gone. He went home. Our second patient was a 1 level. She did fantastic. Her back pain's gone. She was having some hip pain in recovery. And turns out she has an old hip injury, which she actually had seen us for. And like a year and a half ago, but never got treatment. And then I think just laying on the table for so long, you know, on her belly just made her hip angry, aggravated. So we did a shot. We did an injection in her hip, and her pain was pretty much dramatically better. But it highlights the importance of understanding that not everyone just has a disc problem. People have more than just disc problems. People have facet problems, SI problems, piriformis, you know, radiculopathy. Whatever the problem is, they have more than one a lot of times, because even though they have a disc issue and they were pain in their back from the disc down the leg, they walk funny, and that causes other issues. That causes like hip pain, and these are all different areas that need to be addressed, not just the disc. Shot. Okay, so we're working on the L23. After we're done here, I'm going to go to the other side, and I'm going to do the L4551. Shot. So far going well. For her, she's stable. Blood pressure, vitals are all stable. Shot. And she does have osteoporosis. So think about that. This is a patient with osteoporosis who has weak bones, and the only other surgery she could have besides this is Isa. And that's not the only other surgery. It is that my shot right there? The only other surgery would be a fusion. Let me have another glove. No puncture. We're good. I always double glove because sometimes things like that happen where you'll pinch your glove, and that one didn't tear, but you never know. It could be micro perforations. It's not worth keep going. You just want to change your glove for safety because you don't want to give the patient an infection. You know, so it's better to change your glove just in case. That's why I double glove though, because even if my top layer gets torn, my bottom layer is still good. Oh, now we're making progress. All right. Oh. That's beautiful. Everything we do is about safety here at Duke Spine. We double glove, costs more money, but if we have a tear, which doesn't occur very often, it's very rare, we know the patient's protected. It's kind of like wearing 2 condoms.
Well, that's wrong.
You never know when the outer one might get torn. I'm sorry. I couldn't resist that one. I had to wake the audience up because they were starting to sleep. And there's nothing wrong with saying condom. Shot. Shot. All right. Good. Shot. That looks good. All right, so we're inside the L23. We'll finish this up in the next 5 minutes, and then we'll move down to the other side, 4551. Yeah. Are you working with Patel tomorrow? What does your load look like tomorrow?
I have no idea.
Well, that's only pain management. And go like crazy.
Scope on, please. Scope on.
That's all? They're not all anesthesia. We need scope on. Grab her. Is that it right there? Okay, good. So this disc is a bit more collapsed.
Thank you.
Wait. I can feel the pressure on the tube too. Like I can feel it compressing the tube. There's the, what do we call it? What? Huh?
What happened, Rita?
What do we call this little thing? I gave it a name. Diego, help us old guys out. What?
Yes, sir.
What did I call it? The nidus or something? Nidus of pain? The nidus of pain.
Yeah, now I remember. The nidus of pain.
That's it. It's like a little cluster of grapes hanging from the ceiling. Little painful grapes. Blue grapes. You know, the greatest is when you can actually do a little hallucinating, even though you're not taking drugs. It's kind of a gift, you know, having a mind that lets you wander just slightly, to see things in the world a little different than reality, but not have to do it with drugs. I had a very active youth of daydreaming all the time. That's why my teachers would say, if only you paid attention, you might actually amount to something of use to society. I still have the letter from my elementary school teacher to my parents. Something along the lines of, Ara is very bright, but he tends to daydream a lot. If only he could focus on school, he might actually amount to something in society. I love it.
What is this?
All right, here you go. Who's passing gas? Is that you, Jordan? My daughter's a lot like I am. Very smart, but always wants to be making people laugh. You know? Reminds me of myself when I was young. Got me in trouble a lot with the teachers. These are all pieces of herniation coming out. The blue things, it's degenerated nucleus. Okay? We're not going to take all of it out because all of it's not causing the problem. It's only the stuff that is adherent to or interposed within the annular tear. Some of it's just, you know, deeper and not really causing any problem. So we leave that alone. This is all posterior longitudinal ligament. Those white fibers there near 12 o'clock, you can see them at the roof. That's the back of the annulus right here. And all this is nuclear material stuck down to the back of the annulus. So the reason the water is getting cloudy is it's little fragments of herniation that I'm blasting with the laser, and it's just shredding them into tiny little small particles, and then it's just filling the water column up as it leaves the disc space because the irrigation pulls it out. Okay? And that's what we're seeing. Luis, I need a little bit more on the laser fiber. Yep. I'm good. You gave it to me. Thank you. So I actually play with the fiber in my fingers. If you watch carefully, you'll see I roll it. And by rolling the fiber in my fingertips, I can maneuver it around the herniation. I can actually use my belly too. So I use my belly to move the scope. Okay? It's like a little dance. I'm dancing with the endoscope. It's not quite the Macarena. It's more of a kind of like a waltz or a merengue. Yes, yes. But not quite as energetic as the Macarena. Oh yeah. How many people know the Macarena? Huh? So sad. All we have are these TikTok dances, but nobody knows the Macarena. It's an old dance. It was so much fun. Dance as a group. Okay, we definitely need music.
Rita, you know how to put music?
Next case. Next case. Let's do it next case. And we got to play the Macarena, okay? I want to see Jordan dance the Macarena. All right, is my irrigation okay? Just about done here. The last few seconds. So I went to Universal Studios with my wife and daughter, and we were supposed to go on that Velociraptor ride, the Velocicoaster, you know, the new one, and it was shut down. So I said, what happened? The dinosaurs aren't hungry anymore? So funny how comments like that can upset a teenage girl. All right, we're just about done here. Beautiful. Done. Right there. Never mind. Just about done. What's the difference between done and just about done? Nothing if you're Dr. Duke Majan.
We have a new question from YouTube.
Lights on, please.
Yeah.
Will the nucleus of the disc leak out after procedure?
Sorry. I need you to speak louder.
Oh,
Enunciate.
okay. Will the nucleus of the disc leak out after procedure?
Oh, good. So will the nucleus of the disc leak out through that big hole that Dr. Duke Majan's leaving after the procedure? No. No, and the reason is simple. You see this? This is water. The nucleus isn't like water. The nucleus, I want that back, is more like, it's more like, okay, like a hard-boiled egg. You know the egg yolk, the white stuff, when you boil it, it's hard. It doesn't leak. It's kind of stays together, and that's what the nucleus is like, okay? That's what the nucleus is like. So it won't leak out, but it can be squeezed out. So that's why everybody that has this surgery, we give them restrictions. And the restrictions are no bending over at the waist for 6 weeks. And no, you want to come over here?
Yes, sir.
And no carrying more than 25 pounds. So you can't carry anything more than 25 pounds for 6 weeks. So people can go back to work the next day after the surgery if you really want to. However, you cannot bend over, you cannot bend at your waist, you can't lay on the table, have your legs brought up to your forehead by your therapist. You can't do any bending at the waist, and that's why we give everybody a back brace. So if you bend, what you're doing is you're putting pressure on the disc, and you're squeezing the nucleus out, and we don't want to do that. We don't want to squeeze more of the jelly out. So as long as you're not putting pressure on the disc, you won't squeeze any of the jelly out. Shot? Rita? We need your help? Oh. All right. I would come south just a smidgen, 1/4 inch. Okay, shot. Again. Yeah, I think that's, you could see the dye leaking around the nerve roots, like the S1 nerve root. You see that? It's pretty cool. See if you can get the S1 nerve roots lined up. Luis, you doing all right?
Yes, sir.
Shot. I think you got to arc it. Maybe a little bit, just a little bit. A degree. Shot. Again. Okay. So we're going to do L5S1 on this right side first. And this was the one that was really hard to get into. Shot. So I don't know if you can clean that up. Let's go fluoro down to the ground just a little bit. Table up, please, 1/2 inch. All right, I think you're dealing more with a rotational orbital issue than a WAG issue. I think your WAG's pretty good based on that picture. It's just such a horrible blurrogram. Thank God I know what I'm doing. I have great imagination for reconstructing these things in my mind. Oh, that's important, by the way, if you want to be a neurosurgeon. Oh, shoot. That looks off a little bit. Can I see? That's definitely better. Take that for a second. Wee, baba. Shot. 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 All right. These are interesting. They're okay, right?
Yeah.
Are we getting pricing on more?
Yes, and also the scopes as well.
Right? When are you getting that? Oh, you're looking online? Anything?
Yeah,
Anything? Really? Nothing available?
well, there is a Lumbar, but I have in trouble with the server.
Shot.
It's easy to find. The server is easy. Sorry.
Shot. Shot. Uh-huh. Shot. Shot. That's about as good as we're going to get it on the dilator. Shot. That's about as good as we're going to get it on the tube. All right. Tube extractor. Yes. Thank you. I knew that would be tough. Have we cold welded? Let's have this. Bear with us while we do a TV timeout. Just kidding. We don't do TV timeouts. Does anyone do TV timeouts anymore? Huh? All right. Ooh, careful, George. Just shows my age. We need 15 more minutes, maybe 20 max. Once you close that other one. I can see it. Close the other while you're waiting. Stitch, yeah. All right.
Scope on, please.
All right, so we've moved over to the right side. We're now addressing the bottom two discs that are herniated, the L45 and L5S1. So Luis, yeah, look for, this, Can you watch that scope, please? Because I'm at a steep angle. I don't want to contaminate it. The fluoroscope. You mind just keeping it away from me? There you go. Thanks. Thank you. Guantanamera, Wahita Guantanamera, Guantanamera. Any way to play my iPhone music? Like Pandora? If I have Pandora? Yeah? Can do that? What? No, I don't mean now. I mean next surgery. Oh, I need the laser on? Thank you. Any more questions from our audience?
Yes, we have a question from YouTube.
Yes.
Have you used a PRP or stem cell therapy during or after the procedure?
Yeah. Have I used PRP or stem cell therapy during or after the procedure? I did. I did it one time on a patient who really wanted it. And I'm going to tell you, I did the laser, then I put the stem cells in, and everything went perfect. But the stem cells caused so much inflammation in the disc, because that's what they do. They're pro-inflammatory. They cause so much inflammation in her disc that literally she started getting a horrible pain, irritation of the nerve root, because the nerve root's right there. And I really regretted doing it because it just made her healing take so much longer than normal. And it was a lot more painful than normal. So I thought at that time, I'm never going to do this again. It's just not worth it. It doesn't improve things enough to warrant doing it. It doesn't improve anything, to be honest with you. So that's what we call the N of 1, my one that I've ever done. And honestly, it's not very scientific to make, determinations based on an N of 1. We don't normally do that as doctors, as scientists, but from my one experience, I just, how many times do you have to jump out of an airplane without a parachute, right? It's just not a good idea. We know what's going to happen. So knowing from that, the irrigation is sludgily. Thank you. I just wouldn't recommend it. It's more money, and we do stem cells all the time at Duke Spine, but I just don't really think combining it with this surgery makes it better, But if somebody came to me and said, Dr. Duke, I really, really want you to put stem cells, then I'll do it. But I'll warn them that I don't think it's necessary. I don't think it's going to help them. And I know for sure it's going to cost them more money, and that it's probably going to cause a lot of inflammation. So, and then let them decide. The truth is that I don't think it's harmful. So, and I think it's too early to say if there's a benefit or not. So I'm willing to try it again because of my N equals 1. One patient that I ever did wasn't so great. Maybe the next one will be better. I don't know. Good question. Luis, you doing all right? Give me some light over here. I need this light.
Can I have that one?
Can you turn that light towards Luis? Oh, there we go.
This one will be there.
We're good. Luis is good. I got it. You just keep working. Almost done. With this one, there's not a lot to do. So, yeah, stem cells. Love stem cells, but I just don't think that they're necessary, in my opinion, for the Duke laser disc repair. Again, doesn't mean it can't be done. I'm okay. I'm okay. It just means that that one experience I had was bad. And like I said, the patient actually recovered totally and did great, you know, but for like a month, she had a lot of pain that was totally in the disc, and it was totally unusual, unexpected, not typical at all. I never get that. So I knew that that one difference was because of that. It was the stem cells. And I remember saying, I'm not doing that again. I mean, if it made the patient better, I'd do it. But I don't think she got any better than she would have gotten had she not done the stem cells. So I'm not a scammer. I don't believe in doing things that don't make people better. There's a lot of doctors that don't mind scamming. But to me, it's unethical. And I don't need to scam people to you know, be successful. I'd rather fix their problem for them and be successful that way, you know, rather than scamming them to be successful. Okie doke. Done here. Doing all right? All right, good. Having fun? Good. Turn the scope off. Uh-huh. Put it right there. Uh-huh. Great questions. I love the questions, by the way, folks. It shows that the people that are watching are really interested in learning, and that's why we broadcast all of our surgeries, and we broadcast them live, free, and without commercial interruption. Actually, that too. But we broadcast them without editing. These are unedited surgeries. So if you're watching today, you're watching a live stream. And the reason why we want it live is so if there's a problem, you can see it. We want you to see that surgery can be done complication free. And we do it all the time. No complications. Zero, zippo. If we had a complication, you'd see it. So safe. And then of course we have all the testimonials, effective. And you get to ask all the questions. You see everything I see as a surgeon. We don't hide anything. Beautiful. You got the sub-Q good? Like the dermis?
Yes, sir.
And you didn't come out there? That's good. Looks great. So I'm putting a little bit of pressure. Let's get the fluoro in. And once again, we always put pressure when we take the tube out because we don't want the muscle bleeding. We don't want any hematoma in the muscle. Hematoma is a type of vegetable, aka the hematomato, as we call it in the business, the hematomato. It's a tomato made out of blood. What's wrong?
No, I just want to make sure the laser is fine, right?
All right. So a hematoma or hematomata, if you're in the upper northeast, is just a blood clot. You need to be further south. Put pressure here. Shot. So we got our last disc we're going to fix, and let's see if we can't make it pretty. Oh, maybe it's this. It's probably this thing's full of contrast. Try it again. Oh yeah, that's a little better. Okay, that's livable. Shot. That's good. Relax. Relax, relax. Coming out. Shot. Yep. You see the guide wires all the way in. Okay. Needle is down. Uh-huh.
I don't repeat that.
How's our patient? Shot? Shot? Coker? You have another guide wire or no?
Got wire?
Yeah.
Yeah, we can.
No. I don't want you to open another one. Shot? You're kidding me.
It's probably a piece of bone.
Yeah, there is. All right. I'm going to let you work your magic. That won't work. Take the guide wire. The guide wire is the way to go. So we got a little piece of bone from L5S1 because it's so collapsed and there's bone spurs. So when I put the dilator in, it just rammed through a piece of bone and it got jammed inside the tube, and that's what we're cleaning out because we can't do the next level without getting it out. Show it to his boss. Show it who the boss is. We can just get another dilator rather than ruining the guide wire.
Can I have a dilator from that, please?
Let me see. No, you can't go back the other way. Let me see it. I got it.
Right there. Yes, right there. Somewhere there.
That's jammed
Yeah,
in
somewhere
good.
there.
How are you going to get that out?
Oh, I use needles.
Let me see a needle holder. Let me see the coker. So since we can't get the piece of bone out, we're just going to do that later. And for right now, we're just going to get a new dilator. Damn, that's in there hard. Yeah, make sure you get that out, okay? Okay, so we got a new dilator. And what was happening is a little piece of bone was just stuck in there. So I wasn't able to slide it down. So we just got another one. Yeah, Luis, please come to me and let me know. I want to just put together a packet of some more of this stuff.
Yes, sir. Yes, sir.
Because, it's good to have it when we need it, since our volume's up. We're doing a lot more cases now. And I just want to make sure we have everything we need.
Yes, sir.
You know what I mean? Especially with being short-staffed and not having someone help you process in between cases. Right? Last one. 10 minutes and we'll be done. Let me have the tube. How's she doing? Sailing? Comfortably? Happy? That's why we didn't have an MRI, right? So that's why we had a CAT scan on her. We didn't have an MRI on her because she has... Yeah, but I think hers could not. So we went based on her CAT scan. Sean, well, we did a pretty good job figuring out based on the CAT scan. Beautiful. Fluoro out. This is our last disc. We'll be done. We do have one more case. Our last patient is a VIP. I won't say too much, but she did come here and have the laser surgery done on her neck about a year ago. Was very happy, got rid of all of her neck pain at the time, and now she's here to get her back fixed. So today we'll be doing her discs in her lower back. All right. We got 10 minutes left. we'll be done. Any questions from our audience?
Yes, we just got a comment on YouTube.
Sure.
When the healing takes place, will the disc grow back in height?
When the healing takes Diego. When the healing takes place, will the
Okay.
What did you say?
When the healing takes place.
Loud, enunciate.
When the healing takes place, will the disc grow back in height?
All right.
You can hear me?
We all heard exactly the same thing, which was when the healing takes place, will the disc grow
Will the disc grow back in height?
will the disc go back in height?
Yeah.
Is that the same person that asked the same question?
No, it's someone else.
Okay. All right. The answer is no. The disc will grow back. The annulus fibrosus will grow back, the outer wall, but not the jelly in the center. And no, the disc does not grow back in height. Nope. There's no surgery in the world that lets the disc grow back in height. And this disc is going to stay collapsed, but her pain will be completely gone. That's because the height of the disc has nothing to do with the patient's pain. She may stay a few inches shorter than she was when she was 18. But these surgeries are not meant to make people taller. Right? That's not what we're trying to do. We're trying to get rid of people's back pain. So these surgeries don't make the disc taller. They don't give people their height. They won't make people taller. They just cure back pain. I know it's not much.
She can walk straight.
Yeah, she can walk straighter, so she may be taller from walking straighter now that her back pain will be gone. Oh, this thing. But no, it won't make her like taller as a person. Oh, this herniation just doesn't want to come. There we go. I think I finally got it. Well, I guess I didn't get all of it. Yep, we don't do surgeries to make people taller. We do surgeries at Duke Spine to eliminate back pain and neck pain. So that's what we're going to do with her. It's not a bad idea though for the future. Maybe when I get bored of curing back and neck pain, we could start the Duke Spine Institute can start we'll make you a few inches taller than you are surgeries. Huh? What do you think about that? Like enlarging the spine, making it longer so people can be taller. Would you do that, Luis?
I would do it.
You would do it. You would cut your spine open to have bones grafted in to make you taller.
Whatever it takes to make it longer.
Oh man, you're too funny. I wouldn't. I'd be happy with my height the way God made me.
We have Patel here. He said he'll rather wear heels than go through surgery.
What did he say?
He said he'll rather wear heels than go through surgery.
Dr. Patel said he'd rather wear high heels. Is there something you want to tell us, Dr. Patel? Do you have a fetish for women's shoes? Dr. Patel saved the day. By the way, we're almost done here, Dr. Patel, and you're welcome to do your procedure first next. So I know you probably want to skedaddle. Dr. Patel and I work together as a team. He does the things that I don't do, and I do the things he doesn't do. So Dr. Patel is an interventionalist, I think probably the best in the country. And when he does all the facet treatments, SI joint, piriformis, even big joints, medium joints, little joints, treatments like hips, elbows, shoulders, knees, even some smaller joints like hands once in a while if it's needed. All right, here's the back of the tear at L4-5. Pretty monstrous. And anyway, if you are thinking about neurosurgery, spine surgery, you definitely need to either have interventional skills yourself or you need to pair up with a really good interventionalist like Dr. Patel and I pair up. He loves his pain procedures and I don't love doing them, and I love surgery, and he may actually love doing surgery too because he does some surgeries, some smaller surgeries. Is he still there?
Yes, he is.
What do you like better, Dr. Patel, your needle procedures or your surgery procedures that you do?
He says he likes both.
Ah, of course, he likes both. All right. Now, I know that Dr. Patel could have been a neurosurgeon that he wanted to be. And a damn good one at it. All right. Just about done here. This is all collagenized scar tissue. This is the back of that disc at L4-5 on the right side. Look at how thick the scar tissue is. And it's even a little calcified with some dystrophic calcification. You can see that golden color at the laser interface of the tissue. And that gold color is what the laser does to calcium. So there's some more herniation fragments coming out. All right, stand by. The technical name for what the laser does to the tissue is called modulation. Modulation. That's the medical terminology. Laser modulation of the tissue. This is the back of the disc we're seeing here. At 9 o'clock is the end plate of L5, superior end plate of 5. And on the right side at 3 o'clock is the inferior end plate of 4. Just underneath that schmutz right there, just to the right of it. Hey, Dr. Patel, still there?
Yes, he is.
I did my first thoracic medial branch block. I think it was the week you were gone. And the patient did really well. I got rid of his facet pain. I think he's supposed to come back and have a thoracic RFA with you. But he got 100% pain relief. Doesn't mean I want to start doing your procedures. But I had to do it because the patient came from so far away and you really wanted a diagnosis.
Patel said, I guess he's a good teacher.
Dr. Patel is the best teacher, absolutely. No doubt. How many fellows have you taught now, Dr. Patel?
He says 12.
12 fellows. That's impressive. One minute. I'm happy with that. Hey, Barat, have you gone on the Velocicoaster yet at Universal? Did he answer?
Oh no, he's gone now.
Oh, he left. All right, he's probably on his way in or over here. All right, that's it.
Lights on, please.
Good work, everybody. Tough case. Scope off. Just put it down. Put it down. Yep, you can get your other stuff ready. You're just waking up. Everything's fine. Hold on. We've already closed her left side, and we're going to close up the right side in just a moment. I'll apply pressure while you get your stuff together. It's like a giant balloon. Huh? You gonna stitch this side?
Yes, sir.
Good. You're all set.
Okay.
Good work, everybody. Okay. I don't know. All right. Go ahead and type up your questions, folks. Again, this is Duke Spine Institute. You're watching live spine surgery. We just finished the 4-level. L2, 3, 3, 4, 4, 5, 5, 1 for 4 disc herniations. And
there we go. This is how Normally I'm running about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. Years ago, I used to run motocross, cross country, did a lot of different things. But one of the biggest things I did was had a bad motorcycle wreck during that and did an end over the handlebars and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for the matter of an hour, just the way the steering wheel is positioned on the RV, it just sends excruciating pain across my back, gets down to my hands where my hands are numb. Me and the wife, we have to pull over, rest stop. After 2 hours, it's incredible. I just got to get up, take a break, shake my hands. Well, if you're going on a long trip, 2 hours don't get you very far. Just like lifting up this, I was having a hard time getting into my engine compartment. Just every little thing that you take for granted seemed to become a bigger problem and bigger problem as far as my neck. I went to Dr. Duke's to try to get fixed, and he did an expert job. Looks pretty good. Fixed it all up for me. Went in through my neck, went around to hit the back of the spinal cord. I still don't know how they do it. Unbelievable. But no scars, didn't hurt at all. As you know, when I woke up, it was totally painless. My surgery was done on a Thursday. I went back to work Monday. Pretty awesome. Once I've gone to the Duke Spine Institute, it's amazing. Once you take that pain level down, it's like, whoa, there's nothing. I mean, it's night and day. I mean, I just can't even describe it, how good it is. You know, I feel like a new man again. Now that I'm back driving the bus again, it is fantastic. Now we can get behind the wheel, drive for a good 8-9 hours, and then take a rest where I want to and not where I have to. What a difference. Fellas, I'm telling you right now, if you've got the pain I've got, you call me. We'll talk. Anybody can call me anytime. 321-403-8757. We'll talk about the pain. If you've had this, you're gonna want to get rid of it. What a great place right here in Rockledge, Vieira, where we can get rid of it right there. I wish I had known this years ago, but I did laser, Duke Laser Disc Repair. It was great. My name's Randy Quick, and if I have anything else, I know where I'm going. I'm going to Duke Spine Institute. All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. Years ago, I used to run motocross, cross country, did a lot of different things. But But one of the biggest things I did was had a bad motorcycle wreck during that, and did an end over the handlebars, and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for the matter of an hour, just the way the steering wheel is positioned on the RV, it just sends excruciating pain across my back, gets down to my hands where my hands are numb. Me and the wife, we have to pull over, rest stop. After 2 hours, it's incredible. I just got to get up, take a break, shake my hands. Well, if you're going on a long trip, 2 hours don't get you very far. Just like lifting up this, I was having a hard time getting into my engine compartment. Just every little thing that you take for granted seemed to become a bigger problem and bigger problem as far as my neck. I went to Dr. Duke's to try to get fixed, and he did an expert job. Looks pretty good. Fixed it all up for me. Went in through my neck, went around to hit the back of the spinal cord. I still don't know how they do it. Unbelievable. But no scars, didn't hurt at all. As you know, when I woke up, it was totally painless. My surgery was done on a Thursday. I went back to work Monday. Pretty awesome. Once I've gone to the Duke Spine Institute, it's amazing. Once you take that pain level down, it's like, whoa, there's nothing. I mean, it's night and day. I mean, I just can't even describe it, how good it is. You know, I feel like a new man again. Now that I'm back driving the bus again, it is fantastic. Now we can get behind the wheel, drive for a good 8-9 hours, and then take a rest where I want to and not where I have to. What a difference. Fellas, I'm telling you right now, if you've got the pain I've got, you call me. We'll talk. Anybody can call me anytime. 321-403-8757. We'll talk about the pain. If you've had this, you're going to want to get rid of it. What a great place right here in Rockledge, Vieira, where we can get rid of it right there. I wish I had known this years ago, but I did Duke Laser Disc Repair. It was great. My name's Randy Quick, and if I have anything else, I know where I'm going. I'm going to Duke Spine Institute. All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. "30 years ago, I used to run motocross, cross country, did a lot of different things. But one of the biggest things I did was had a bad motorcycle wreck during that, and did an end over the handlebars, and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for the matter of an hour, just the way the steering wheel is positioned on the RV. It just takes some excruciating.
All right, you're live.
Hello there, I'm Dr. Duke Majan, and we have just finished a Duke laser disc repair that was done on 4 discs on a patient who had 4 damaged discs, the L23, 34, 45, 51. Now, she didn't have an MRI done like most patients do to diagnose the damaged disc because she has a pacemaker. So she couldn't get an MRI. All she could do was a CAT scan. CAT scans are not quite as good as MRIs at diagnosing painful herniated discs, but you can still do it. If you got a good quality CAT scan, you can use it. And we did that today. We tested each of those discs with the dye, and all 4 of them were painful for her. And when you have a painful disc, what it means is it's inflamed and it's definitely causing patients pain. So we all have discs that are not painful. If we did a discogram on a not painful disc, you would have no pain. If we did a discogram on a herniated disc that was not painful, you would have no pain. The only time the discogram is positive for reproducing pain is when that disc is a painful, inflamed disc. And when we do the discogram and the patient says they have the pain, we always ask them, is that your typical pain that you get every day? If it's not their typical pain and they never get that kind of pain, they'll say, nope, never get that pain. We call that dissimilar or discordant. Those are just 2 words for the same thing. It means it's not their typical pain. So what we want to see as the operator, we want to see that the discogram reproduces their typical daily back pain or neck pain, and that we want to know a number, like how bad it is. Plus, we could look at the X-ray while we're doing the discogram. We can actually see the dye leaking out through a tear in the back of the disc. And that's what we saw today, okay? So, what questions do we have?
All right, for this procedure, what can you promote is the quickest way to heal?
Okay, for the Duke laser disc repair, what's the quickest way to heal?
Yeah.
Well, first of all, you don't want to re-injure the disc that we just fixed, all right? And a lot of patients get confused about this because the pain is now gone. They don't have it anymore. They think they're healed, but they're not healed. The disc takes 1 year to heal. When you cut someone's skin and they heal, it always heals in a week. It's like healed in a week. But when you heal a disc, it takes literally 12 months to heal. And the reason for that is your skin has lots of blood flow. So when you cut the skin, and then when you're done with the surgery, it's got a lot of blood flow, so it heals quickly. Whereas the disc itself has no blood flow to the inner half of the annulus where it needs to heal. Only the outer part heals quickly. So for the disc to completely heal through and through, outer to inner part of the wall, you really need that blood flow to have time, because mostly diffusion is the way the nutrients move from the areas where there are capillaries and blood flow down to the parts of the disc where there is no blood flow. So diffusion takes time. It's basically gradient driven. So we have concentration gradients. So of course, where the capillaries and the blood supply are in the outer part of the annulus, you'll have a lot of whatever, glucose or oxygen. And then for the glucose and oxygen to penetrate to get to the deeper part of the disc where the tear is being healed, where there is no blood supply, it relies on diffusion. And diffusion takes a long time for things to move through diffusional gradients.
Okay, cool. All right, this next patient, he had surgery on L3, 4, and 5. He wants to know if he can still use an inversion table after surgery.
So a patient had an L3, 4, L4, 5 surgery, but I don't even know what surgery they had. Do we know what they had done?
No. But he wants to know if you can use an
They want to know if they can use an inversion table. So here's what I would say. I don't know what surgery you had done, but if you had an artificial disc put in, you don't want to use an inversion table. The inversion table could cause a stretching of the bones. It could pop the disc out. So do not use an inversion table if you've had artificial disc surgery, unless you talk to your surgeon and they give you the thumbs up. On the other hand, if you had a fusion done, then it's fine. If you had a microdiscectomy done, it's fine. If you've had a laminectomy done, it's fine. If you've had a Duke laser disc repair done, it's fine. So I really don't know what kind of surgery you had done. If you had a spinal cord stimulator put in, you don't want to be getting on the inversion table, because that inversion table is just going to make you Like it could make the lead move because you're basically you're pulling your muscles and soft tissue and spine apart. So I would say depends on the type of surgery you had done, but for the most part it should be okay unless you have a spinal cord stimulator or artificial disc.
And cool. And this last person just wants to know your thoughts on his incoming fusion on L5.
On what?
L5.
But what?
He's having an incoming fusion. He has one.
You want to know my thoughts on a fusion you're having done at L5S1,
Yes.
I suppose, or L45?
Mm-hmm.
My thoughts are don't do it.
Okay.
Why would you do fusion if you don't need to? Fusion is highly invasive, damaging to your body. They're going to cause scar tissue galore back here. I wouldn't do the fusion. Do a laser surgery. That's the whole point of the laser surgery. I've done over 1,000 fusions in the lower back in the L4551 region. 1,000 patients. That's a lot of surgeries, a lot of fusion surgeries. And I can tell you right now, even if you do the surgery perfect, there's tons of pain after surgery that lasts for probably 6 weeks or 8 weeks. And you got to take painkillers for 8 weeks. You can't really work probably for 8 weeks, maybe even longer, because of the pain and the narcotics you're on. The laser surgery, we could fix your L45 or L5S1, we could fix it in an hour. And you do an hour recovery, you can go back to work the next day, light duty if you want to. But the whole point of these endoscopic laser surgeries is so you don't have fusions. So if you want my opinion on fusion, I still do them, but only on people that are not good candidates for the laser. Okay? So what a fusion does is it basically bolts your bones together, and if they're taking the disc out, they're going to take that out and put a cage in there. But a lot of surgeons don't even do fusions the right way. Probably 9 out of 10 fusions that I see in the lower back are done improperly. They don't correct the alignment. The curvature is not right. Like, see this curvature here? You're supposed to have a curve backwards. A lot of surgeons, they fuse you on a table that's straight, so the spine is straight or curved forward. You don't want that. That's going to pitch your whole body forward, and then you're just going to sit there pulling your back up, and your lower back's going to hurt like heck afterwards. You get adjacent segment disease because you're trying to straighten your spine back so your eyes are on the horizon. I can't tell you how many screwed up fusions I've seen. So what I do is we come from the side, like this, up here. We don't come from the middle. We come from the side. We go right through a natural opening already there. So we're not messing with the muscles, the ligaments. We're not creating scar tissue. I'm literally coming in and just zapping that disc and repairing it. Forget about fusion, folks. If you're having a fusion and you're stuck on it, that's fine. I hope you're doing the right thing. It's really complicated. Like I was talking about earlier, one of the biggest problems I see with spine surgeons is they don't treat all the discs that need to be treated during the surgery. The patient may have 2 bad discs or 3 bad discs, but the surgeon only fuses 1. And then, they don't care because that's a shorter surgery. They get paid a lot of money anyway. And then you're going to be coming back and having another fusion at the next disc next year. So you're like an annuity to them. You're going to keep bringing them money every year. That's not how I practice medicine. That's not how I do surgery. I fix everything that's causing pain in one surgery. It's one and done. The patients go home, they recover one time, get on with their life. I don't keep bringing them back like an annuity like a lot of these other surgeons do. I don't know what to tell you. If you have to have a fusion, you have to have a fusion. But if I were you, I'd do everything I could to avoid it and have the endoscopic laser surgery we just did today instead. Let's run a video and show them how the Duke laser disc repair works. Can you pull that up for them?
I can send them the link. It's not safe on this computer. I can send them a link in the chat. It's not safe on the computer.
What? Okay, well, that you have to be able to show that video.
No, I will.
All right. Okay. Well, I guess that's it.
Yeah.
Have a good night.